Good afternoon. I'm very honored that I was invited here together with my partner in crime, Marie-Jeanne Wolf. Um, uh, I hope the expectations, as Björn said, are not too high. I'm the only one, I think, who's telling something about financing care, and we do that in Holland uh, by insurance companies. Um, uh, I want to tell you today something about how we make innovations possible. And we do that in a way maybe is different from your country. So we can maybe talk later what the differences are and what we can learn of each other. My name is Anna Krüger. As Björn said, I'm a former midwife and since almost 10 years working as a medical advisor in the insurance company Achmea. It's the biggest of Holland. We have 4 big insurance companies for health, and our company has 5.5 million insured people. We have 17 million people in Holland, so it's a third almost. I want to tell you in the next. I have to look. Yes, how we work now. We work in a partnership. When we want to innovate the care in the health system, we need each other. We need the health professional and we need the insurance company. That's the way we do it in Holland. And we need therefore a common vision. And we have to work on that. And we have to know the needs of the clients because they are for us the most important because we have to know what they need, what they want, what is comfortable for them. And then we try to make the quality and the efficacy transparent. So we all know we try to know what we are doing. But change is always difficult. We are now in a process almost for 10 years in Holland, changing the organization of the not only the care, it's always in moving, but also the system of insuring. And it's now partly private, partly with legal guidelines. And as you all know, the system of market, the market system is in Holland also now in our healthcare a very important way to work. And it's discussed and it's not over the discussion, but we are now in it. And so everybody who is attached to healthcare is very busy with the changes. And everybody has ideas, but healthcare is a big field, so it's difficult to have one way. It's not necessary, but we have also a need to change because the costs are only growing, and the needs also, or the needs we think we have. In the beginning of life, we are still more investing in life, in healthcare, and at the end, we get older, and so we have to find a way to control the costs. And we think that innovation is an important way to really know what we are doing and make it transparent. And in our system in Holland is that we start when there is an innovation made by professionals. They design a product and they come to the insurance company with it. And in this case, it was the professionals from the AMC in Amsterdam and our company who have the most insured people in Amsterdam. And then we have the legal guidelines to make the innovation possible. That guidelines that provide us with rules, but also with the possibility of making our own product together, to fix a price together, and then make it possible that you have a period of 4 years to experiment with the product. But what is our goal with this innovation? Our paradigm now in our system is not efficacy on its own. No, we think, and we have learned that the last years, that quality is his own efficacy. Quality, when you have a good quality, then you don't have to do things again. You have less infections, as we heard of boo-boo. You have also less problems to fix things again. So our idea is that we have to work on quality, and that when you can manage to put the quality in a second stage, and you can always make things better, because the world is changing, the patient is changing, our tools are changing. So there's always a need to change and to look at quality. And we think when you are really working on that, then you get better efficacy. That is our basic idea about efficacy. So that's important for you to know, that we as an insurance company not only looking for the money, we have to do that, because it's our responsibility, but we have also to think about how we do that, how we put our responsibility. And then the second one on innovation. What is then important in that innovation? You see at the end I mentioned the efficacy, but first it's important that it is family-centered, the product, that it is equitable, that it is accessible for all the people, and it is effective. And I put also the circle of evaluation, how you we use that tool more and more, the PDCA cycle, and it will help to always look for what are you doing and what are the results. And then more concrete, how we have the product, we have the idea about quality and about the use of it. And then in Holland it is normal that you make a business case. You try to know what was the old situation, what is the new situation, and what are the costs and the benefits. We saw it also with boo-boo. And that ratio is important to know, is it not only a good product, but is it also something we can afford ourselves. Then the legal authority in Holland who's busy with pricing the products. It's an authority, the Dutch Health Authority is it called, and this organization decides on the strategic position of the product, because there are a lot of products and you have to place it in the field of the total healthcare. And this product that we have made is now strategic placed in the basic healthcare package. And also the authority makes a description so that everybody knows what is this product. And that is published by the Ministry of Health. What is important in also fixing the price is to, when you have placed it in a position, then you also have to know where is the old product or parts of the new product, where were they in the field, and what do you also want to reach or change when you make a new position, because we see that more and more care is given in hospitals, and that is very expensive care. And we see also that the first level of care is more and more ignored by clients, but we think also because they think that is not so good as the specialist care. And we think that we can help everybody. The clients pay by the insurance company, and the professionals, they are high educated, that we all can try to give more comfort and more trust to the clients, that it is also possible to have a lot of things more in the neighborhood in the first level, but not to forget also at home, because there everything starts. Sometimes we are a lot of mechanical ideas about care, but we are in Holland. It was normal to have your conception at home, but also your baby at home, and we are driven away from that idea that a lot of things are normal and that we can do them at home. So that's why we are thinking about what is now important of substitution of care again back to the more normal way of care giving. And then at last, what we made agreements in this new product. And for us, it's as insurance company, it's very important that we have the monitored outcomes, that we really know what does this product do. Also, that you adjust when you have the outcomes, that you change what is necessary to change on the basis of the needs of the clients. And it stays important that the price is on the real costs and not to get more profit of it. And every 6 months there's exchange of data in this project, and every 3 years we evaluate, and then we again want to know, are we working in the right direction? I think this was the last one of mine, and now Marie-Jeanne will follow up.
And Marie-Jeanne is a physical therapist, as we heard, Yeah, I lost you on the floor. Previously, and she was also a researcher in all these studies from the Amsterdam group.
Thank you.
Thank you very much.
Thank you. First of all, I would like to thank Inga and Bjorn for inviting us to this conference and that we have the opportunity to talk about our program. Let's briefly go back to the aim of the TOP program. That's a preventive early intervention program to strengthen the resilience and development of very preterm infants and their parents after discharge from hospital. So we know the evidence-based results of the RCT, and Rod showed us this morning, this morning, yeah. The results of the RCT. We know what the health insurances want, but how are we going to implement these results? And how are the results to be sustained or even improve? So that the health insurances remain satisfied, and most importantly, that the parents receive the best quality of care. A quality of care that meets the current needs of the parents and children. This implicates that the development and new ideas continuously needs to be incorporated in existing evidence-based interventions, since RCTs do not have an eternal life, and that the definition of evidence has to be expanded to include accepted scientific principles from biological and social sciences after an RCT or a benefit-cost analysis study has been carried out. To implement our evidence-based intervention, we therefore use promising and even untested intervention strategies during the implementation period, after the RCT in 2008 and the start of the implementation in 2010. We did two things, and Karen told you this morning already. At the same time, we disseminated the post-discharge intervention program in the Netherlands, and at the same time, we wrote a new curriculum protocol that differed from the intervention that was tested in the RCT. We called it a TOP program. The idea of not waiting until there is a new evidence from new RCTs, which we all know will take many years, but strengthening the evidence by including other sources of knowledge and including other promising intervention strategies in the program, was also strongly advocated in a recent article by Jack Chonkov in the Journal of Development and Psychopathology in 2013. Shonkov proposes that intervention programs should make use of a short cycle sharing, and this requires a flexible approach to planning and action that promotes quick turnaround time for information exchange and gives the opportunity to develop, adjust and sustain the intervention program with the aim to better meet the needs of the parents and children and to guarantee the best quality of care. Parents tell us that they want quality of care at an affordable price. Quality of care means doing the right thing at the right time, in the right way, for the right person, and having the best possible results. The WHO defines quality of care as care that is, and you have seen it in the previous slide by Anna, should be family-centered, equitable, accessible, effective and efficient. But how do we measure the first components of the WHO definition of quality of care? How do we know that the top intervention is family-centered and that the approach is strength-based? How do we know that the relationship between parent and therapist is based on respect, equality and is equitable? First of all, our trained top therapists are registered in a quality register after certification, and they sign a contract with an expertise center, our expertise center in Amsterdam. The therapist also signs a quality policy document attached to the contract, after which they are allowed to carry out the top program. The quality of the top therapist needs to be transparent and will be continuously assessed on the basis of parent reports written by therapists after each home visit. They are saved in a database and reviewed by quality assurance staff of the expertise center. Reports to medical specialists are also saved in a database. Both the parent reports and the reports to the medical staff can be retrieved later for audit purposes. The therapist attends 2 compulsory postgraduate training days per year. The therapists support at least 5 preterm infants per year and attends quarterly intervision sessions. The therapist will be able to obtain individual coaching if needed. Registration and re-registration in a quality register of the expertise centers takes place every 2 years, after fulfillment of all the above mentioned requirements. How do we measure the overall quality of care? The efficiency of the program is measured with care-related indicators and patient experiences via a consumer quality index, parent interviews and care diaries. The effectiveness of the care is measured with the Hospital Anxiety and Depression Scale, the Alberta Infant Motor Scale, and the Ages and Stages Questionnaire. The orange measurements are digital questionnaires that are filled in by the parents using the CLIck system, a very user-friendly system, and if you are interested you can view it on the website because it is also translated in English. The next question is how to analyze and evaluate efficiency and effectiveness in order to improve and guarantee and sustain the quality of care, and how to ensure that improvements in reality reach the target group. We choose to use an integrated dynamic quality care model to meet the above mentioned requirements, that is to keep the quality high and try to sustain the program. According to the WHO, an integrated care model is a concept bringing together inputs, delivery, management and organization of services related to diagnosis, treatment, care, rehabilitation and health promotion. Integration is a means to improve services in relation to access, quality, user satisfaction and efficiency. The model works with continuous feedback loops, with the aim to continuously develop and improve the content of the program. We train, support and coach the interventionists, as Karen told you this morning, in order to offer a high-quality, state-of-the-art intervention. We focus in particular on central steering for both the care process and the care content. A good working infrastructure, including of course a website and electronic patient files, is essential, as well as good management and data collection. Moreover, external stakeholders should continuously be involved. For example, the Parent Association, the Dutch Health Insurances, the Dutch Health Care Authority linked to the Ministry of Health, and the Dutch Pediatric Association and Pediatric Physical Therapy Association. To measure the parent satisfaction with the program and the efficiency and effectiveness, the collected data are saved in a database, analyzed and evaluated on a daily basis. To guarantee the quality of the intervention of the top therapist, we evaluate all the elements I mentioned earlier. The results of the analysis and evaluations of the data are then used to adapt, modify, adjust and further develop the content, structure and process of the top program. This means that both the content of the intervention and the structure and process may change at any time. This way, all elements of the integrated dynamic quality cycle are continuously adjusted to meet the current needs of the parents. A staff of 12 work in the expertise center to carry out all those different tasks. Okay, state of the art of the top program at this moment. At this moment, we trained of 45 top therapists are working in the Netherlands, and at the moment we are training 24 pediatric physical therapists who are going to be certified this year. We try to cover all the provinces, but that takes a few more years. We estimate that in 2017-18 we cover the Netherlands, and that all preterm born infants and their parents are able to get the top program. So far in the implementation period, more than 1,300 children were supported by the top program. And we see, if you see it in the blue line, that the mean days of hospitalization, of hospitalization, because they were born in the hospital, is 27 days, and that almost 29% of our group are multi-births. One of the aims we wanted to achieve was a reduction of the needs for care during and after the top program. We took a representative sample of the total cohort and found that almost 25% of our children was readmitted first year of life, compared to 40% in our historical control group. 70% visited the emergency department, and in the control group this was 29%. One child was registered with child abuse, and in the control group this was 6.4%. 13% needed continuation of pediatric physical therapy after the top program, compared to 22% in the control group. This slide shows the causes of rehospitalization. First of all, we see that 25% of our children is rehospitalized for acute respiratory diseases. And remarkable, 23% is readmitted because of vaccinations. This slide shows the results of the hospital anxiety and depression scale. 30% of the mothers had a score above the clinical range of 8 points regarding anxiety, and almost 24% scored in the clinical range regarding depression at the start of the top program. The differences in scoring between the start and the end of the program were all significant. However, we should keep in mind that there is a time interval of 1 year. Moreover, we do not have a preterm control group. Reference norms show in the right column that the differences between the end of the top program and a reference group, that they are not significant. The high levels of anxiety and depression at the start of the program clearly indicate that the parents are in need of psychological support. 29% of the mothers and 6% of the fathers received psychological counseling. Most parents received counseling from a psychologist, and about 15% received counseling after the program had ended. This slide shows the results of the Consumer Quality Index filled in by the parents. The slide gives an overview of 4 years. Parents were always very satisfied with the knowledge of the interventionist and the advices given. Parents would advise the program to other parents, and they were satisfied with the information before the start of the program. But at the beginning of the implementation, they were not at all satisfied with the written information. And that was right. We did not have the proper information at the beginning, but gradually over the years this improved as well. The parents gave the top program on a scale from 0 to 10 an overall score of 9. Finally, I would like to conclude with a take-home message that to implement and sustain the quality of preventive early intervention programs, a dynamic cycle model is essential. This dynamic model implies that we all dare to take risk and that we should not be afraid to learn from failure. Thank you.